As I said, the 5 LCGs are committees of the board, so they are not autonomous bodies in their own right. They're not health social service bodies, but they are committees of the board. So what do we do then? Well, we have to plan and commission the services for our local population in response to those needs. And we then have to secure those services by engaging with different providers. It's largely the trust and primary care and a range of voluntary and community bodies as well. And then we monitor the performance to ensure that we are getting what we commissioned and that the services are meeting targets and they are of considerable quality and meeting the assessed need. So that's what we do. We have a local commissioning group which is set, and the composition of that is prescribed in the legislation. We have 17 members who commit to 2 days a month. The non-executive members commit to 2 days a month. So we have 4 GPs, a pharmacist, Lawrence is our pharmacist rep, a dentist, 2 voluntary and community sector reps, and we're very fortunate that the 2 ladies who work with us have extensive experience in mental health and long-term conditions and bring a wealth of expertise and experience to that role and are very much at the forefront of emerging thinking on the whole self-management agenda around long-term conditions and patient and public involvement and self-management strategies. So that's been a very useful bonus for us. Also on the group we have 4 local government representatives, 4 councillors, and that may well be changing with the restructuring of local government next year, so we wait to see how that pans out. We also have aside from those non-executive members, we have a number of people who work in the Health and Social Care Board and the Public Health Agency. So we have our public health consultant, our nurse rep, our allied health professional, and 2 social workers, 1 in respect of children and 1 in respect of older people as well. And wrapped around that local commissioning group, we have what we call a business support team, because in County Hall and Ballymena, there are a whole host of people engaged in commissioning services for local populations. And so we have the benefit of commissioning, finance, information, public health, social work. So a team effectively wrapped around that local commissioning group to support it in the commission of service. Because largely the people, the GPs, the pharmacists, their time is limited. It's 2 days per month, although Lawrence is able to do 10 days per month as chair of the LCG. So it's important for us that we have the staff on the ground to support the local commissioning process. Commissioning in the northern area brings its challenges. We have some 470,000 of a population shared across 10 district council areas, although that will change next year. And we have quite a finely balanced rural and urban split. We go from the Glens of Antrim right down to Newton Abbey. In terms of our East Antrim population, we find a lot of those will tend to use services or acute hospital services in Belfast. And in the northern area, we're probably in the northern LCG, we have what we call a significant amount of cross-boundary flow, in that our patients don't always access the services in the Northern Trust, but our East Antrim patients may well gravitate towards Belfast, and our North Coast patients may well gravitate towards Altnagelvin for trauma and orthopaedics and ophthalmology. And we also have some activity delivered in the southern area in Craigavon Hospital, some babies being born for our Tyrone population. So we have significant flows of patients. So although the Northern Trust is the main provider of our services, quite a lot of what we commission from other trusts as well. We are very much rooted in the local community. I think the wealth of experience that our local government and voluntary and community sector reps bring to bear in our proceedings certainly gives us a very clear and firm grounding in the needs of the local populations, because they feed back the experiences they have had in their constituency offices, or the GP's frustrations. They will feed back what their patients are telling them about what services need to improve and where we could do things differently. And certainly that's been very beneficial in informing our plans. We also meet on a quarterly basis with local government in its wider form. We only have 4 local government representatives on the LCG, but we have 10 councils at the minute. So every quarter we meet with 10 chief executives and a nominated councillor, and that's a forum for sharing and exchanging information about their agendas and about ours as well. And we find that emergency care and older people services and all the current topical issues feature very prominently on that agenda.
And just to add that that's a partnership relationship rather than us leading on it as such. It's a partnership with the councils, was established with the council.
We also have various channels to engage with user groups. Primarily around older people's services, we tend to find that they're better mobilised and organised, and there are a number of older people's groups that we engage with, and they would very frequently attend our LCG, our local commissioning group, public meetings as well. So there are a number of older people's groups that we're actively involved in, and whenever the LCG members sat down last year to reassess their priorities, one of the emerging priorities was that they wanted to hear more from the voluntary and community sector and hear the patient and client voice coming through. So as far as possible, we try to make sure that every other month we bring somebody from the voluntary and community sector to give their perspective on services, perhaps the services they deliver and how we can ensure that we work in tandem with them and align our agendas and objectives.
Okay. Yes.
I'm not sure if that was 5 minutes,
Nope.
but...
Nope, you're very good to time. No, that's grand. I mean, maybe if I could ask a couple of questions first. We've had the benefit of the document, the commissioning document, and I suppose two things I was struck by, both in terms of some of the evidence we've had in the hearings that we've done, and in the document itself. And you've mentioned some of the public participation and involvement activities you're involved in. I was struck by comparing the Northern and the Western Trust, where the Western Trust actually has a section on what it's done in terms of PPI. And I didn't find one in the Northern, and then I got to the next steps, which was kind of where you're going next, which actually, in the final couple of paragraphs, actually talked about the importance then of particularly around transforming your care, going out to the community and looking at listening to people, and both in terms of primary care and secondary care providers, but also the general public. So I wonder if you could say a bit more about exactly what your PPI involvement is, how you do that in practice and what it looks like. But I have a second part to this, which is that I'm also struck by almost everyone we've heard from seems to be doing some of that work. If you talk to the trusts, they're involved in it. If you talk to the Public Health Agency, they're involved in it. And I wonder if you'd want to comment on, looking from the outside, about the coherence of that. There are clearly some advantages of everybody doing it. That means everybody's listening and listen, patient voice, etc., etc. On the other hand, the coherence of all that's being done and how you draw that together so that actually, what you're hearing, what PHA is hearing, what trusts are hearing is all shared in a way that's coherent. Mm-hmm. And I wonder whether you think my concern that perhaps the kind of drawing that together and the coherence is a concern that I should have, or it's something that actually is not a problem. So just take us through what you do with PPI, and then...
I suppose we didn't have a separate section on PPI because we were trying to mainstream it into all our activities. So rather than seeing it as a stand-alone or an alongside activity, we've been trying as far as possible within resources to mainstream it so that any time we're working on a project, we look to see how we can get the patient and client voice and the users and stakeholder engagement into that. And there are different ways of doing that, and we try to tailor it to whatever we're looking at. So I'll give you an example. A couple of years ago, we commissioned an acute assessment area in Antrim Hospital. We found out that patients who had been to see their GP who were acutely unwell would typically have had to arrive at ED with a letter from their GP and be triaged again and wait with everyone else for treatment. That had been a particular frustration for GPs and for patients. We've been working very closely with primary care. We'd been at a series of public meetings around transforming your care and heard very clearly from the audience that people didn't realise why, whenever they had the letter from the GP, they had to wait with everyone else in ED and be triaged again and join the queue. So we worked very closely with GP colleagues and with clinicians in the trust, and a group was set up then to look at developing a service that would actively allow those patients to bypass ED and go straight through to a dedicated assessment area within Antrim Area Hospital. And we incorporated the views of users, primarily at that point, I think, from our GPs. We were working closely with local GPs who were sharing with us the frustrations of patients, but we weren't getting to the patient voice, and we were quite clear that we were relying on GPs for that. So whenever the service was initiated and we were monitoring performance, we developed a feedback form for the GP to fill in, And through that, we asked for the patient experience of using the acute assessment area as opposed to going through ED. And we kept that process ongoing for 6 to 9 months afterwards to get some insight into what the patient experience, good and bad, was like in terms of using the acute assessment area in Antrim Hospital as an alternative to sitting in ED with the letter from their GP. But we were looking very clearly to our GP colleagues and to trust colleagues as well who had practical experience on the ground of delivering the service to give us their feedback. But certainly the patient feedback form that the GP completed, good and bad, was able to give us that sense of PPI and let us know how this was improving services and what more could be done actually to enhance the service further. I take your point that from an outsider looking in, it must look very messy and very muddled, and that everybody's doing PPI, and sometimes it may look like we're at cross purposes. So how do we share that information? If I can give you an example of some work we're doing around carers, and then explain how we've tried to work with the Trust to make sure that the PPI involvement from carers is as joined up as it can be. And we're very mindful that carers are a very pressurised group. The demands on their time are many, so we don't want to make this any more onerous than it needs to be, and we want to fit in with their schedules. Last year, the local commissioning group commissioned short breaks for carers because we really recognise the valuable role that carers have to play, very often an unpaid role, long hours and not much respite from it. And there is a carers group in the Northern Trust, and a colleague of mine sits in that group as well. So it's a band of carers who come together every quarter to discuss caring issues, the pressures they are feeling, and the services that should be designed to meet their needs. So it was from them that we heard that they would really like some short breaks. That's what would make their caring experience more tolerable and would be best for them. So we commissioned the short break services, and now we're working with that same carers group to evaluate the benefit and the impact that that particular investment has had. So we haven't set up a separate carers group because there only are so many people out there. They have a lot of demands on their time. So we're working closely with the Trust. We're trying to make it into a coherent process so that the carers group that the Trust has gathered together, that we can effectively piggyback that group and we can have access to that same expertise and experience, but we're not redesigning the wheel and setting up a separate carers group. So I think that's a good example of us working together and trying to get some cohesion and alignment in terms of our PPI activity.
I suppose maybe I would add in around, yeah, I agree with you in terms of the coherence. It is difficult to see where it's at the moment, but I suppose if you take the other example of your transforming your end-of-life care, where the Trust are involved in it, it's a Delivering Choices programme. It's been delivered in conjunction with the board and Marie Curie, where I co-chair it along with the Trust lead on palliative care services. So you have users and carers within that, and in the workshops that were organised around the needs assessment around that, and the patient involvement were done together collectively. So that's an example of it. Regionally, that's how it has been best done since I've been involved within commissioning and within the delivery of services. So there's good examples of how it can be done. And I think as well within the northern area, when you look at patient involvement, it's how local is a locality. So we probably have 4 distinct localities within our area, with Antrim, Ballymena, East Antrim, Causeway and Mid-Ulster. Sorry, I nearly forgot where I come from. So you have you've got 4 distinct localities, and those populations have been around 100,000. It's easier to get engagement across groups and across, even for patients and carers to meet together, or patient groups to meet. They're more comfortable within those localities in terms of. So we need to try and streamline as we go forward within our next few years how we engage at that level. One advantage we have there slightly is we've got carers and community involvement on the ICPs. So we've got some on the integrated care partnership. Sorry for using terms. I hate to do that one in the health service. We all do it. But within the integrated care partnerships, there's opportunities there to engage at that level, particularly around respiratory, diabetes, those areas where they're leading on. So we need to look as a local commission group how that develops over the next few years. But they're in their infancy as well, and people are finding their feet within it. But at least they're engaging with communities before they're commissioning the services. And the one confidence I would give you around it is when we do get a bid or a bid for commissioning of a service, particularly a new service over the last few years, the table that we have around there are quite robust in terms of ensuring that that there has been user involvement or patient involvement in the setting up of the service, or the suggestion of what the service might look like. And many's the time at the workshop level, because we get our members around the workshop, we batter it back a lot to the trust to say, show us exactly where that happened at, and if it didn't happen, make it happen before it comes back to us. Or have you thought about how it might even deliver it using a different model, using community involvement rather than just a medical model all the time for all issues? So, but it's work ongoing, and trying to get the coherence around it will be a constant struggle. And it also will require some resource if you're going to do it at a locality level, because it takes someone. It's no point taking it at a point in time. It has to be constantly rechecked and gone back over.
Right. And the second question, which is really, again, our experience in the public hearings has been, and all of the trusts we've been and heard from, they've all given us very good practice examples of quite often relatively resource-light issues that are being done, for example, in emergency departments and in ancillary services which are clearly vital to the pathway of patients in and out of emergency department. But I think we've been struck as a panel that quite often good examples stay within the trust. And again, it may be an unfair impression, but I'd welcome how in practice you see, for example, within the board, if either the Northern Trust is doing something that seems to be working, how you make sure that other trusts are aware of something, and by the same token, how you become aware of Southern, Western, Belfast, Southeastern is doing something that might be very useful for you, how you become aware of that. And perhaps you could give me an example, if you think there is that kind of knitting together to make sure good practice is spread out amongst the, and in commissioning of services. Give me an example of something that you have commissioned in the Northern Trust that you've rolled out you've seen roll out elsewhere, and something that you've commissioned after you heard from another trust that, well, we tried this and it worked.
The acute assessment area that I mentioned was actually built. We actually modelled that on a service that's currently running in the Belfast City Hospital. So how did we get to know about that? We have public health consultants who have expertise and a remit for all acute services across the 5 trusts. So we had shared with her the particular frustrations of GPs and patients in terms of patients going through ED with their GP letter. And her advice, I said, oh, look, I know there's a model in Belfast City Hospital that's worth having a look at. You will need to tweak and tailor it to your particular local circumstances. So I think there are lots of opportunities for us, because we're a relatively small body of people across the board, the LCGs, the agency and the trust. There are lots of opportunities for interaction and engagement. There are some formal events where we share learning and exchange best practice. And there are a number of those events around emergency care where everyone will bring along and showcase the particular thing that's working well for them. And we sit back and we think, yes, we could do that, or we could do something similar, but it may need to be a bit different. So there are those formal events where we showcase best practice and get the learning. But aside from those formal events, there will be a range of other opportunities where we are going to engage with clinicians and managers in other trusts and LCGs and the board and agency, and just that informal learning. Then we will also pick up on things that are happening or how they've managed to solve some problem that we are wrestling with, and then take their advice and learning from that and take it back for consideration locally and see how this could be achieved locally. So there is that sort of cross-fertilisation of ideas, and we're very keen to continue with that, whether it happens on that more formal learning event or an informal network.
Can you give me an example, say something the Northern Board commissioned that you then saw roll out elsewhere as a...
Yes, yes. I'll come back to that one if that's okay. Yes, where we saw it rolled out elsewhere. Yes, I know we've taken examples from other areas as well, and I know other areas are now looking at things that we have done in emergency care, for example. Yes, one that we have developed and that has been rolled out elsewhere.
Unlike Mastermind, you can pass.
I'll pass and come back to that if that's okay. Yeah.
I think just to follow up in terms of the engagement and how you might share information, we would meet once monthly as the LCG chairs and the assistant directors of commissioning with their own agenda, bringing in the directors from the board to look at what, when required, to give us information around their roles. But ultimately, that's a big opportunity to share what we're commissioning within the locality, or what's not working, or what isn't working. So we use that forum, it's once a month, to share best practice, and also to challenge when practice hasn't gone right, to be fair as well, which is important. And we also have the Transformation Programme Board, where we're all involved in, where examples of good practice are brought through the ICPs particularly, and you look at that there, would that suit your patch? Could it be rolled out? Would the GPs buy into that within their locality? So there's a lot of work going on around that at the moment, and some of the bids that are coming through now are very much around that. When you look across the integrated care partnership bidding processes, you can see obviously the regional input is there, but you can see where people have looked at what's happening in Belfast, what's happening in Northern, and said, oh, we as a group of GPs, or a group of GPs with community, would deliver that type of service. So there's be a lot of examples coming out of that over the next year or two, I think, as we go through.
Okay, thank you. And final question from me, which is, again, on the performance measurements in emergency department, the 4 of the 12-hour target, and there are clearly other targets about not having readmissions within 30 days, etc. And we've had mixed evidence, I think, from trusts. Some who've said that the 4 of the 12-hour target are not really great indicators of quality. They bring headlines with them, but actually there are a whole series of other ways, and therefore the kind of quality framework from trusts is often measured in a much more drilled down and deeper way, although they know they have to be cognizant of the 4 and 12-hour target for kind of public reasons. And I noticed in the kind of, again, the commissioning plan, really you have nothing is said by the local commissioning group about the 4, the 12-hour, the readmission targets or anything. They state those are the targets essentially coming from on high in a sense. So I wondered whether you have a view from within the board and the local commissioning group about the 4 and 12-hour targets and how good a measure of quality they are, and whether actually you think there are other measures of quality that are much more important, or whether you think the 4 and 12 hours are actually the key indicators that people should follow.
Well, the 4 and 12-hour targets are the Minister's targets, so yes, obviously we will have cognizance of those going forward. And the Northern area has faced its own challenges over the last number of years in meeting both the 4 and 12-hour target. The 4-hour target, it has improved, but maybe levelled off, and it's still not at the 95% achievement rate. The 12-hour target, there has been significant improvement in recent months and over the last number of years in Antrim Hospital, and particularly so in Causeway Hospital. And we're very keen to see that maintained and sustained, and we will work with the Trust to try and ensure that we can together harness our collective energies to make sure that that improvement is maintained. There are, of course, other indicators of quality. So if you're lying on a trolley for 12 hours, it's probably a fairly reliable indicator that you haven't received the type of service that you would wish for yourself or a member of your family. And the same with the 4-hour target as well. If you've presented with a relatively minor injury, you may expect that you should be seen and treated a lot quicker than 4 hours. So there is something about the quality of the service that we offer. The 4 and 12-hour targets are there, but they're not the only indicators of quality. And I think we need to drill deeper in terms of the patient experience, the feedback from users and carers, to get a more holistic insight into what we should be measuring. So we still have to measure the compliance with the 4 and 12-hour target, but I think we need to cast our net a little wider in terms of getting some sense of the patient experience, because it is more than 4 and 12 hours. Yeah. But at the minute we do collect the data on the achievement of the target, but I think you're right, we need to look a bit wider about the whole patient experience.
But in the last couple of years, particularly when the turnaround team were working within the Trust, we would have liaised with them very closely in around the quality of care as well, and we would have had Mary Hines and Paul Cummings at the LCG describing not just the targets but the issues around and patient flows and the quality issues as well. So we're listening to those as well. I suppose one of the advantages we have is we got the 10,000 voices to come to the LCG at an early stage, so to try and encourage them to get more responses from the northern locality. I think we had 438 or something, which was a bit higher than some other areas. So that has been achieved. Now the role for us is to look at what's coming through in that in terms of ED and minor injury units in Marfelt and White Abbey, and see what the quality issues are coming through in that, analyse that, and then I think we can improve it. Those measures are ministerial targets. The 12-hour one I think is a must do. As far as I'm concerned, no one should lie in a trolley for 12 hours. You cannot say that's quality care in any society. The 4-hour one, I think we should have a debate around that as we go forward. But there are other issues around quality, and I mean, as an LCG, we focused on the patient experience within the ED and try to build the confidence of the community around Antrim Hospital, which was suffering at that time. So we challenged the trust to, first of all, to show the quality to us, and then to try and give that message to the community. So we were in support of them, while at the same time challenging them, and as a commissioner, which you have to do in terms of their targets, but supporting them in terms of the difficulties they were having, and also then communicating that to our public through our counsellors and through our press releases.
But there's something for us as well about how our services are structured. For example, there's a minor injury stream in Causeway and Antrim Hospital. So if you arrive with a minor injuries and you're sent to the minor injury stream for something that requires maybe basic stitching or suturing or some treatment, you would reasonably expect that you should be seen and treated a lot quicker than 4 hours. If you require a diagnostic, an MRI, a CT scan and some bloods, it's not unreasonable to expect that those other steps in the journey will take some time. What we're looking to do is to make sure that people who have a minor injury are streamed into the minor injury stream and can get turned around as quickly as possible. And we're trying to encourage more use of our standalone minor injury units in Mid-Ulster Hospital and White Abbey Hospital, where the turnaround time is indeed a lot faster than 4 hours, and where people are seen and treated in a much more timely manner. So there's something there about patient selection and patient choice as well, that patients who have minor injuries perhaps can present at a minor injuries unit or can self-select and go to the minor injury stream within the ED. And there's something there about imparting that knowledge to people and making sure that everybody knows what is the appropriate course of treatment for them and the appropriate place to attend at that particular time. I
suppose, sorry, I'm just going to add another thing. We've been working closely with Dalriada out of hours, because only recently local commission groups have been charged with commissioning of out of hours GP services as well. So they use different quality indicators, and they do the measurements in terms of response times and all that, but they have some different innovative type ways of measuring quality that I think can be applied to the casualty or the ED emergency service as well. So and also getting those GP out of hours in our area, it's Dalriada out of hours, getting them to, we've had 2 or 3 meetings with clinicians from Dalriada and clinicians from the ED, and saying, looking at patient flows and looking at why patients move from one area to the other, and trying to improve what would be for the patient, where they would access the service. So there's a lot of work to be done around that because of the size of our locality, but it's something that we're up for that challenge, I think.
Okay, thank
Sorry,
you.
Les, just before you hand over to Marion, if I could come back just with the example of something that we've done that's going to be rolled out in other areas. Very glad for the extra thinking time, so thank you. We have in place a dermatology project at the minute. I know it's not related to emergency care, but we have been actively training a number of GPs in recent years, or in the last year, to effectively manage more routine dermatology, skin conditions in primary care, and to avoid the need for a referral to secondary care. There's a growing number of referrals every year to secondary care services, and especially so around dermatology. So what we've done is upskill GPs, brought in an accredited training programme, and given them the skills to manage more primary care, more dermatology conditions in the primary care setting. And where we've identified a number of GPs in each locality, we've been able to offer them as a resource to other practices, so they can effectively hold dermatology clinics within their locality and deal with a whole range of minor skin conditions. And that's now being seen as an example of best practice and will be rolled out elsewhere in terms of helping other trusts meet waiting times targets for dermatology conditions. And in fact, I think it's a model that we could use for other specialties and services as well, in terms of upskilling GPs to manage more in primary care.
Okay, thank you. Marion.
In your presentation, you talked of the local commissioning groups as the local expression of the Health and Social Care Board, and you also referred to that there's a business support team attached to the LCG, and I'm wondering, what is the interface between the LCG and the Health Board?
The interface is at many different levels and in different areas. So the LCG as the 17 members of the group, or as the wider group of people who work in the northern locality, the 17 members of the group. They are a committee of the board, so they will meet every month. Lawrence will attend the monthly board meetings as chair of the LCG, and the other chairs will attend the board meeting as well. The non-executive members on the LCG probably don't have that much interaction with the board. They will see board minutes and board agendas, and on occasion board directors will come to talk to the LCG. So Dean Sullivan, the Director of Commissioning, has been to speak to the LCG about commissioning priorities. Sloane Harper, the Director of Integrated Care, has been to speak about the primary and community care infrastructure development. So there is engagement at that level at LCG. Lawrence will have more engagement with the board, given he is chair and he's 10 days per month. Most of the members of the LCG, the non-execs, have 2 days per month and therefore have limited time and capacity. But we do share minutes, we do share papers, and every month at the public meeting I will do an update of things that have been happening across the local commissioning group and the board to give them a sense of emerging thinking and new developments, so that they are, as far as possible, stitched into what is happening at the corporate board level as well. And Lawrence will do an update in terms of his exposure to board meetings.
But it's a very valid question. It's a tricky management, to be honest with you, and it's done as best you can within the time we have. But certainly, the Transformation Programme Board is another opportunity for myself to attend and get an understanding of what's going on in the transformation agenda. And we, as I say, we have. If appropriate, a director come along, like the statutory residential homes, which is a huge issue within the northern locality, we would have someone attend and talk to us from the regional group on that, because they were leading on it. So there's lots of opportunities, depending on what area you're looking at, to engage. But from a member's point of view, and I was a member for 5 or 6 years before I was chair, you know, I'm engaged a lot more as a chair. So my role, I'm very conscious of my role to bring on board and keep my members on board and up to speed as to what's going on, and to guide and direct Bride and the staff to ensure that people are brought up to speed for as much as possible within the time frame they have.
And how does that link in with the business support team's link to the commissioning team at the board?
The business support team that I referenced in my opening statement is a group of people who mostly, but not exclusively, work in County Hall across the different directorates of the Health and Social Care Board and the Public Health Agency, who help us commission services, who input into that role. So we have finance staff who will give us the finance advice, information staff, nursing staff, allied health professionals, social workers. So whenever we're looking at a business case or a development, we can actively call on those people to work with us and support us to commission the service. Because although we are commissioning directorate, we do need that advice and support from other areas, and that's effectively who is on our business support team. It's the wraparound group or the structure that supports the commissioning process. They would be board and agency staff. The agency, obviously, with the nurses and the public health consultants and the allied health professions. But there is a dedicated bunch of people there who we can call upon to support us in their local commissioning processes and agendas.
But there's a constant debate, and I don't mind saying it, around the numbers of people and staff and where they're placed and where they should be placed, going forward. And that's the debate that will have to be taking place as we go forward. In terms of actual resource and numbers, but it's an important debate that needs to take place to ensure where the lead is coming from within each area.
You talked about funding going to the voluntary and community groups. Would the contract for that funding, would that come from the LCG or does that come from the Health Board?
The contracts that we currently manage tend to be legacy Northern Health and Social Services Board contracts. So there are a number of those in place, primarily with children's organisations and also some voluntary groups around long-term conditions and physical disability. So that funding, at the end of the Health and Social Services Boards in 2009, that funding was either allocated to the board or agency, and then those contracts have been continued, and there's a rolling process now of retendering to look to make sure that we're abiding with best practice guidance on procurement and all our obligations around that.
And I've only one, actually I have two questions. One of them is you talked about your acute admissions unit in Antrim, and that GPs can
Refer
really
directly.
have direct admissions there, is that
Yes,
right?
yeah, direct.
How is that working, and how does that impact on waiting times in the ED department?
About somewhere in the region of 10 to 15 people every day will present at the acute assessment area. GPs will typically see the patient in the morning and realise they are unwell and need some intervention by hospital. They will ring the acute assessment area, and sometimes they will be given advice around the management of the patient, and sometimes that is sufficient for the GP in terms of the ongoing management of that patient's condition. So sometimes it's just the element of advice which is enough. Sometimes the doctor who picks up the phone in the acute assessment area will say, I need to see that patient because there are a range of investigations or bloods that I need to carry out to make a diagnosis. And they will arrange a time for the patient to come up to the acute assessment area, and the doctor in the acute assessment area will organise all of the various tests or diagnostics and assess. And sometimes, roughly about half the time, the patient is admitted, and sometimes about 50% of the time the patient can be assessed, treated and discharged home. So what it means is that every day that 10 to 15 people who would in the past have tipped up at our emergency departments in Antrim Hospital are now going through this alternative portal in the hospital, and they're not arriving at our EDs, they're being dealt with separately because of this a new development in the hospital that's been agreed between the GPs and the hospital doctors.
So when you look at the ED numbers within Antrim and you look at like a steady state, you know, in effect that if you take 10 a day over a year, 3,600 say, they're going through a different route. 50% of them are still being admitted to hospital. But so it sort of blanks that there's no extra demand. There's extra demand, but it's been moved moved in another way. And to be fair, when you look at some of the qualitative and quantitative analysis around that, it's the patients. It's a great way to be treated, rather than particularly if you're long-term condition and you can get straight to a ward or a bed area where you can be assessed properly and maybe managed and returned home if possible, which a lot of people would prefer. So it's.
And what would be the average length of stay in the acute admissions unit?
The patients are then admitted to their ward, a base ward. So our average length of stay in Antrim is just over 4 days.
4 days. Mm-hmm. Okay. And my last question, my last question, is the integrated care partnerships. Lawrence, you had mentioned those. Can you tell me a wee bit more about those and how they're going to emerge from the PCPs, is it?
Yeah. There's a lot of complicated words and letters that appear within the health service. We're very good at it. The integrated care partnerships, there's 4 within the northern locality, and they're based around the localities I said earlier, Antrim, Ballymena East, Antrim, Causeway and Mid-Ulster. So they're partnership committees with GPs, pharmacists, community and trust representation. They're in their infancy to some extent. They've been about 18 months or 2 years maybe, but even at that, just forming a group and getting them together is taking time. They've a clinical lead and a small business support program that supports their processes. They're working only on those 5 areas: the respiratory, diabetes, end of life, frail elderly
and stroke.
So they're working on just around 5 clinical areas, which to some extent there's gaps then, you know, in terms of what they might be looking at. But and they bid through the integrated care partnerships. They put a bid into the transitional funding as well, in order to put in a bid for a service they might deliver. But the idea being that whatever service they would deliver will remove the need for that person to be in the hospital or reduce the length of stay for those people in hospital. So while there's a notion of funding going into that, it's transitional funding that has to be moved from trust to integrated care partnerships. So the rules and the process of it is complicated. In reality, when you look at the bidding process, the money can either go to a trust to deliver it in a community setting or to GP or community pharmacy or dental through a local enhanced service. So there's some flaws in my view in terms of how they've been structurally set up, in terms of how you can finance them to really drive change. But we are where we're at with them. But there's some elements that I would like to see. But it'll take policy change in order for some of that to happen.
Thank you very much. Thank you.
Paul,
Thank you so much, Bride and Lawrence. I really appreciate you finding the time, and I think at quite short notice, so we really appreciate that. I've got two questions actually to begin with, which might just be beyond your portfolio, in which case, say, ask someone else. In a recent Northern Trust report, there's reference to 12 local governance groups, and I haven't yet got clear what they are, and I just thought that possibly you would know. If not, that's fine. Because
yes, I know there's a governance committee in the Northern Trust which is charged with all areas of governance across the Trust. The 12 governance groups is new to me, but what I can do is I can go and find that information out and share it with you. But I know there's a governance committee and there are governance structures being reviewed, but the detail of the 12 groups within the Trust, no, I don't know.
Yeah, and all I know about them, some of them are related to corporate governance and some of them are clinical governance. So it's first of all, disseminating that is the starting point for it.
Well, we thanks for the offer, Bride, but we can pursue it
you
with
can
the
pursue that with the Trust,
with the Trust. Thanks. And the second question might fall in the same category, but since you're both here and you might know the answer, the Northern Trust, the Western Trust has a PPI annual progress report, and I wondered whether the Northern Trust has a PPI annual progress report. Perhaps you don't know. I mean, it's not in your portfolio, so it's very understandable if you don't.
I haven't seen it. I mean, I know the individual who would be responsible in terms of their Equality and Human Rights Manager. I would imagine that they do capture, perhaps within their annual report, some account of all their PPI activity. I haven't seen a separate report, but it may be incorporated within other documents or publications.
But just I would add that we do know that they're quite robust in their PPI. We've observed it and listened to it firsthand, and we do challenge it, and we do know that it's
how they fund it. I'll come to later.
That could be a different one.
I think I understand the process. Thanks to your interventions, I understand the process of preparing the local commissioning plan. I wondered if you could help me with what happens next. So there is a commissioning plan, and it's been prepared in a consultative way, which is commendable. So what happens next? It goes up to the commissioning board, and it forms part of, am I correct in thinking that it forms part of what the framework document calls a commissioning plan?
That's right.
Could you kindly elaborate?
That's right. So the commissioning plan has been drafted, as you said, in this consultative and collaborative way. Right. So this year it's one composite plan. It's the overall commissioning plan for the board and agency, and incorporated within that the 5 local commissioning plans. Okay. That then was presented, that came to our LCG and presumably to other LCGs as well for information and approval. So we would have taken our members through all the various programme of care and explained what our commission intent was for the following year, and made sure that they were comfortable with the direction of travel and understood how it fitted in with the wider strategic objectives set by the board and agency. Those plans would have been ratified by each LCG and then would have gone to the board. Right. And the board earlier this year would have approved the commissioning plan as a fit-for-purpose response to the commissioning plan direction, which was issued by the Minister. And things just haven't proceeded as smoothly this year as they would have done in previous years because of the wider financial context. So you'll appreciate that the plan hasn't been approved, and obviously discussions still ongoing around the finance.
Okay, so then the commissioning board then adopts what the framework document calls the commissioning plan, within which there'll be the 5 local commissioning plans. Right. Yeah. Okay, and then what happens? Thank you. Then what happens? Okay, so
it goes to the Minister, and we wait for the Minister to endorse it. Right. But at a local level then, perhaps that's what you're interested in?
No, I'm interested in
going
to the Minister.
It goes
to the Trust?
It goes to the Department, and the Department there may be some further engagement between the Department and the Board, some more iterations. But ultimately our expectation is that the commissioning plan would be approved, and the financial platform on which it is built would be agreed and approved. And that's perhaps the stumbling block this year. That's what hasn't happened because of the wider financial impasse. But it goes to the Trust as well. So the Trust will have cognizance of and will understand the wider commissioning plan, and then will look more focused way in our Northern Local Commissioning Plan. Sure. And in response to that, they will prepare a Trust delivery plan. a TDP, a Trust Delivery Plan.
Right.
And in their Trust Delivery Plan, they respond to the various actions that are
commissioning
within
intentions.
the commission intent and say how they will meet those over the course of the year,
Right.
how they will achieve the targets, and whether they expect to achieve all of the various targets in the commission plan direction. And they will also signal whether additional resources may be required to enable them to meet the targets.
Right. So when it comes back from the minister, it's then got, I think you called it a financial platform, it's then got a budget attached to it, the commissioning
That's
plan.
right.
Yeah.
So in your local commissioning plan, I think there are 17 different headings, if I remember rightly. So would each of those have a budget line?
What we have is a budget line for each programme of care. So each programme, POC1 is acute, then we have children, family and childcare, older people services, mental health and learning disability. So our budget is given down what's called programme of care lines, and then we have to work with our finance colleagues to understand, because life isn't always as neat as that and isn't as neatly categorised as that. So obviously some developments that we are commissioning will straddle across a number of different programmes, and we have to try and understand which strand of money and which POC line it's coming from, and then work with finance colleagues to make that happen and join the
But
dots.
if that's agreed with the trust through their delivery plan, then there's a service and budget agreement, which states what they'll deliver and what we would expect for that delivery, quantitatively and qualitatively.
Okay, so the commissioning plan has gone up to the minister. There are then monies attached. It's then probably approved, maybe tweaked a bit, but approved. Monies attached to it, and then it'll go back to the board, and then from the board back to the trusts.
That's right.
And then they'll have to they'll have to prepare their TD plans.
Trust delivery plans, that's right,
Okay.
yes.
Okay.
But it's a round circle. The trust would be informed, and there'll be local meetings with Northern Trust and Northern LCG staff as to what the intentions will be. It's not. Hopefully, there wouldn't be so many surprises. People should understand what the direction of travel is, and we should be listening to them as well as to our users in there.
So will each trust have a TDP for emergency care?
No, each trust will have a trust delivery plan that says how it's going to meet all of the various targets and commission intent for 14-15 or for whatever the particular year is. So within the trust delivery plan, it will say how they intend to meet the 4 and 12-hour target, plus all of the other targets that are there, and how they intend to address our other commissioning intentions.
Right. So in the local commissioning plan that you've prepared, there are 17 headings, and the last one is emergency care. It's called something else, but it's emergency care. So will the trust not have to prepare a TDP in relation to that commissioning intent?
They will have to prepare a narrative and respond to that commission intent, saying what they are doing to achieve the 4 and 12-hour target in their emergency care departments. And they will perhaps say where example, their current performance is against 4 and 12 hours, what they've done in recent years to improve that, and what they plan to do over the next 12 months to actually improve that further and achieve the target.
And they could say at that point, well, the minister or the commissioning board, no, it's the commissioning board, you're earmarking this money, X million, for emergency care, but we think we need more. They could say that, and then there could be a discussion, and then they're probably told, sorry, the budget is complete.
They mostly will say that, of course.
Yes, they for a number of cases, they will maybe sort of what we call RAG rate, red, amber, green, the various targets. So they will say, yes, we are comfortable that we can meet that particular target in year, and we have sufficient resources. Or amber, no, we think there may be an issue because we haven't been able to recruit the staff. Or, sorry, the green, yes, we can deliver. Amber may be an issue around recruitment. And they may say in some cases, no, the target is red. We don't think we can comply with that target in year. And it may be that additional resources, they think additional resources may be required. Or there may be some other reasons that they advance to explain why they may not meet the target.
Okay, thank you for that. That's helpful for me at least. Maybe my colleagues knew.
Can I just say about trust delivery plans, because we are in this uncertain situation at the minute, the trust delivery plans are still in draft form because the commissioning plan is still in draft. So the usual commissioning cycle hasn't completed its cycle at this point in time.
Thank you for that. I've got a couple of questions, things I don't understand about the commissioning plan, but I'm not suggesting that I've found any great flaws. It's more that I've got a flawed understanding. So page 5, for instance, talks about what I'm calling deprived groups. That's not the phrase used at page 5, but that's what it means. And then at page 13, there is reference to the importance of, it's a heading, addressing inequalities at page 13. So page 13, the top paragraph, the second line says, the health of the population has improved over time, but this improvement has not been seen in all groups. Pattern of health inequalities is persistent over time. So it's page 13 at the top paragraph. There's reference to addressing inequalities, and then page 5 there's reference to deprived groups. And then the second paragraph talks about the plan. Okay, I'll just pause for a moment.
Sorry, I'm looking
It's
at
okay.
No, I need to find just the relevant section because our pages are numbered.
You probably know it, Bride. It's. I just want to make sure we're figuratively, perhaps not literally, on the same page. So page 5, for instance, are you on page 13 or page 5?
I'm on page 30, no, I'm actually on page 210 because this is where ours starts, so we're definitely not on the same page at the minute. If you can give me perhaps the heading of the section, I can find
so
it.
There's the chairman's forward, and then there's the northern.
Is it it's the actual northern plan itself? It
Yes.
isn't the okay.
It's the local commissioning plan, not
thank
the.
you very much.
Yeah.
Thank you.
Okay.
Thanks very much.
So at page 5, at the bottom, there's very rightly there's. Right at the bottom there's reference to, unfortunately, some inequality has endured, right at the bottom, do you see? And for health outcomes for certain groups, and then it refers in the last line, particularly deprived groups. And then if we just jump ahead to page 13, it's page 13 of, is that okay?
Yeah.
And there's a key challenge, and very fittingly, the first key challenge is addressing inequalities. Are you with me?
Yes,
Yeah.
yes, we're here.
And it talks in the second sentence, it talks about the health of the population has improved over time, but this improvement has not been seen in all groups. And then there's the next paragraph makes the same sort of point. I suppose my question is, what I don't understand, and I'd be very grateful if you could clarify, is that having signalled that there's this important issue of deprived groups, and having signalled that a key challenge is to address inequalities, what I don't see from the plan, I'm not saying it's not there, but what I don't see from the plan is how the Northern Trust is to address those inequalities. Do you see what I mean?
Yes, yes.
So then I turn over, you see, and I see the wonderful table with the regional commissioning objectives and the local commissioning intent, okay, with the 17 headings, one of which is scheduled care. But what I don't understand, and I'm sure you have a very apposite answer, but what I don't understand is here's a key challenge of addressing inequalities, quite rightly, and then I don't see where that is in the commissioning plan, the commissioning intents of your plan. And if it's not in the commissioning intents, it's not going to be in the budget. And so I'm just trying to figure out how you're going to address, how the local commissioning group anticipates the trust will address these inequalities.
No, that's fair.
Maybe just by way of background, obviously the wider determinants of health are more than health and social care services can address, and
For sure.
yes, so obviously there's a need to work with other partners, local government, education, and other stakeholders,
the PHA
and the PHA
is
as well.
sitting on your board.
That's right.
Right.
Yes, the PHA.
And
so
it doesn't have a budget of any significance in comparison to your budget.
no, but they support us in our commissioning
Right.
role, and
Right.
we rely on their advice and support in order to carry out what we need to do. In terms of the life expectancy and the deprived groups, there is some work underway through the integrated care partnerships to look at the long-term conditions. And what we were doing then in terms of signalling to the trusts, who are key partners within the ICP, that we wanted to work on the development of pathways from prevention right through to palliative care for people with respiratory issues, diabetes, stroke, and the frail elderly. So if it isn't as explicitly developed
you
in the
just
Commission
mentioned
plan.
Conditions, Bride. You just mentioned conditions,
Yes.
really important conditions, not deprived groups. So it wasn't rural, urban,
Yes.
people with disabilities, children in care. Do you see what I mean?
Yes.
So
It isn't as explicitly connected. I think that's what you're saying, that we've made the link. We've said that we need to focus on deprived groups and communities. Inequalities persist and outcomes are still not as good as they should be for certain deprived groups, but we haven't clearly enough made the link between what we plan to do in response to those inequalities, and our Commission intent should be much clearer so that the Trust can have a clearer indication of what we're looking to commission and do differently. Probably, I presumed from a drafting, that's something we will take on board next year, that we need to make the link more clearly between deprived communities. We would expect, for example, our integrated care partnerships to give us a sense of where the hotspots are for different conditions in different areas, and they would tell us there's a particular issue in East Antrim around diabetes. So we would have that information fed back, and therefore we would be encouraging any pilot project around diabetes to start in East Antrim, for example, because of the prevalence there in East Antrim, for example.
Just to follow up on that as well, like say the Cookstown area, which is a high incidence of coronary heart disease, we would have a project there working on healthy hearts in conjunction with the Trust. So there'll be individual pockets of activity around deprived localities, first of all, looking at the deprivation, and then there's other areas in around disease state across the localities.
because I would have thought there has to be outreach for rural communities, local socioeconomic groups that are at the bottom of the pile,
Farm and families, etc.
etc. So, and that's what I didn't see in here, but I did see diabetes and particular health conditions, but I didn't see the disadvantaged groups and how they were to be reached.
And I think that's a point we need to look at then going forward to make the links.
No,
Can I just say, just
Thank
on
you.
page 13, it does talk about the family nurse partnership, and at the heart of that model is a need to reach out to young mothers from deprived communities with very little social support. So in some cases it may not be explicit in that where the focus should be, but for the family nurse partnership, for example, the focus would very much be on young mothers from deprived backgrounds without the support structures in place.
I agree, Bride, and actually, I want to be scrupulously fair about this. At page 18, there's reference to vulnerable adults. So I'm not saying that it's completely invisible, but it is underdeveloped. That's what I felt.
No, that's a fair point, and one we'll acknowledge next year.
Thanks for that.
That's actually useful as well. To be fair, that is useful. It's useful feedback.
It's useful to have a fresh pair of eyes because we read these and reread these, so it is useful to have a different perspective. That's very helpful.
Well, in that spirit, if I may, Bride, you noted that the PPI is absent from the commissioning plan, and you said that PPI is being done. It's a bit messy. I've no problem with messy. There are many stakeholders contributing. I completely understand that. PPI is complicated, so many stakeholders are going to do it, and I think it's bound to be a bit messy, and I don't think that's a bad thing, actually. But then you said that PPI is not in the plan, but it's mainstreamed. And I have to say, in the same spirit that we just engendered, I have difficulty buying that, because just because something's mainstreamed, it doesn't mean that it should disappear from the plan. It still has to be in the plan. And my fear is that if it's not in the plan, it will disappear, So in the spirit of our exchange.
In retrospect, I think that's a very valid point. It wasn't included as a separate section, but I think to give it the profile it deserves and to remind people of the need to do patient and public involvement, it should be referenced in a separate section, and that's a deficiency we will pick up on next year.
And that's for the trust, because you want the trust to reflect the paragraph 5 in the framework document about PPI. So if it's not in the plan, there's a risk that they won't take it as seriously as you would wish.
Absolutely,
Okay.
and I think that's a very valid point, and we'll note that for next year.
Okay, thanks. And I don't know whether you have a different view about this, but it's the same sort of point, really. And I'll stop flogging this horse shortly, rest assured. But it's about equality and human rights. So the Northern Trust has these really important equality responsibilities under Section 75. We all know about those. Mm-hmm. It's also got important human rights responsibilities under the Human Rights Act. So again, looking at the plan, I don't see where the commissioning board's funds are for this to enable the Northern Trust to fulfil these statutory responsibilities? I mean, I know this isn't a funding document, but if it's not in here, it ain't going to be funded, right? So where is it? How can we expect the Northern Trust to honour its equity obligations and its human rights obligations if it's not getting a sou for those obligations? Do you see what I mean?
I think you're quite right in that we need a hook in our commissioning plan, and we need a very specific and explicit reference to this. I know the Northern Trust has their Equality and Human Rights Manager. There's a unit there. That post was funded, as with other trusts as well.
Yeah.
So you're
it's
right.
There.
It's there, but I think we need to profile it and give it a sense that it is something that is foremost in our commissioning plan. And I think we will remedy that next year. It's been very helpful to have that observation.
Thanks. You've been very patient. So my last point is. It's about competition, actually. It's a larger point, and I'll make it briefly, and we don't really have time to look at it in any detail. But my limited understanding of the reforms of roughly 10 years ago, one of the reasons was to engender competition. That was one of the ideas that sort of drove it. And that partly explains why we've got the 5 trusts and so forth. But I don't see a lot of competition. I see there's some competition, and you alluded to some of it actually, but I don't see a lot. And it seems to me that the idea of it being driven by competition, hasn't really flourished, but what the trusts have become are not sort of 5 competitive bodies, but 5 sort of regional bodies for the delivery of health and social care. And I don't have a problem with that, but my question is, with a competition, where's it gone?
Competition, I suppose, then, in terms of the internal market, and that was at the basis of those reforms. We do tend to commission most of our services from the local trust.
Yes.
That seems to be the position. We do have substantial contracts with other trusts as well, given where our populations tend to move towards for services, as I alluded to earlier. We do commission significant services as well from primary care, the dentists, the GPs, the pharmacists. We do have a smaller number of contracts with the voluntary and community sector as well, and those are all now being examined and re-tendered. But it's a very valid point that perhaps there needs to be more competition in the market. I know, just for example, in terms of home care services, the Northern Trust has, as have other trusts, recently increased the provision of independent sector provision into home care services. So there is a growing opportunity perhaps that's now being taken to look at diversification of the market, but it is something I think probably we will be looking at more critically over the months to come.
It's quite difficult in a small region to do it, to be honest with you. I would like to see more of it personally, but ultimately, maybe through the ICP model or through the federations or through other NHS bodies, we can outsource work. That's one way of doing it possibly. The 5 trusts tend to use the discussion stroke argument that if you move funds around or move funds away from them, it could destabilise them in some way. We have a lot of regional services from a northern perspective which are delivered in Belfast mostly, and some in Derry, Londonderry. So would we maybe like to deliver them in our own locality? Yes, possibly. Shifting that around and getting the will to do that is a difficulty, and it's a difficulty for commissioners and for trusts. What we do have, though, is we do have the equity review, and we look at it, and we look at what does it cost to deliver a service through one trust versus another. Right. And we're looking at how then, if it's cheaper to deliver a service in Southern Trust, for example, and they have staff and availability, and we have maybe a patient waiting list, can we divert? So we're looking at it, but getting it done is difficult.
Yeah. Brian, I'm not. It's not for me to say, but I'm not encouraging you to ramp up competition, actually. But I'm just curious, where it's sort of gone in the mix. And one reason why I'm not sure that it's always going to be appropriate is that it's the point that Les made earlier. There can be good practices, from trusts. But if the concept is they're in competition with each other, they're unlikely to share those good practices. Now, my wish, from the human rights point of view, is that good practices should be shared across the region.
Absolutely.
But if it is deeply competitive, and at the moment I don't think it is, if it is deeply competitive, then that sharing of good practice is unlikely to happen. So I'm not asking for more competition. I'm just asking a bit mischievously, where has the competition gone? But thank you very much for your patience.
Thank you.
Pride and Lawrence, you've been put through your paces there, and as you
problem.
can see, we've read your local commissioning plan. If there's anything that you want to, and we said this to everybody who's given evidence, augment or to provide us in writing, that's very welcome. But in order to give you the opportunity to have any final say, either in terms of something you think you haven't had a chance to mention that you want to, or to augment something you've said, just the opportunity to make any concluding remarks. You don't have to take that up, but it's just if you do. Or
Yes,
any
no, I
observations.
certainly will reflect on that, and if I think additional information would be useful, we can certainly let you have that,
Yeah,
yes.
yeah.
And thanks for Paul's comments, because I think it's good to have a fresh pair of eyes in our commissioning plan, because we read and reread something, so it's useful to see something with a different perspective and to look for key themes, so that's been very helpful as well.
It's been really useful, and I know
Mm-hmm.
you've come at pretty short notice, so thank you. Thank you very much indeed.
As you can see, I wasn't very well prepared. Apologies.
No, you're fine.
Thank you very much.
I thought you did fine.